better sleep, sharper focus, a healthier life? It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
I'm Dr. Liz Turner. Today we're going to talk a bit about breastfeeding medicine, and how oral ties or structures relate. I want to bring some clarity to something that can be super confusing to understand, especially because there's so much misinformation out there. So what I really want to highlight is that breastfeeding is so multifactorial. And though we're going to speak more specifically to breastfeeding, the act of it of feeding at the breast, there are so many benefits to breast milk itself. And so for those of you that are pumping and bottle feeding, know that your child is getting so much nutrition, so much immune support. And don't be discouraged if your journey hasn't been exactly what you want it to be, or what you would have chosen for yourself. I personally have been through these things, and that's one reason I focus so much on supporting parents, especially mothers who are in the throes of the breastfeeding diet and having some difficulties. So what I really want to highlight is the benefits of the structural impact of breastfeeding. And so for those of you that know me, I focus on craniofacial growth and development of infants, children, and adults. And when we have an infant, a rapidly growing child, there's a huge opportunity for change and improvement of the facial structures, especially that of the midface, and surprisingly, in a breastfeeding child, the lower jaw. The lower jaw is very hard to get to grow, and most of the growth of it is completed in the first 2 years of life. It's fascinating how these jaws grow at different rates and for different reasons. And the lower jaw especially benefits from rotation and forward movement in the first few years. So we'll talk a little bit about that too. So we're going to dive into why breastfeeding isn't just about bonding and nutrition. It's really shaping your child's face and airway. I want to talk a little bit about jaw development. So really, the roof of the mouth is the floor of the nose. And we did ourselves a disservice when we dismissed the mouth from the rest of the body, when dentistry and medicine got separated, because they really should be together. And so for a lot of us that are in this space, we are often fighting an uphill battle, not just the lactation consultants and the manual therapists we work with, but the dentists that are really focused on airway health as well. Because since this wasn't taught years ago, it's hard to bring in something and have it not called new. Breastfeeding and growing babies has been there all along. It's of the utmost importance. It's how we procreate and how we keep on going as a society. So the roof of the mouth is the floor of the nose. The tongue is meant to be nature's expander. The lips and the cheeks more passive, like nature's braces. So think of it like this. Where is your tongue right now? It should be up against the roof of your mouth. It should be filling that U-shaped arch of your upper jaw. If it can't do that, there's a chance that you too may have a little bit of narrowness to your upper jaw and your whole midface. Well, so the tongue up against the roof of the mouth, the lips and the cheeks more passive, kind of creating a seal, but not really creating a huge grip to put excessive inward forces on the teeth and the jaws. So babies are so malleable. Have you ever seen a baby in a helmet, one with a flat spot? Well, that's from pressure, right? So they're laying in a certain position. Maybe they have torticollis, or they just like to be on their back. They're in a container a lot, as a lot of our babies are. And they get a flat spot on their head because their bones are so adaptable that even the smallest amount of pressure can create change. How many of you have grown-ups have had teeth shift from orthodontics, or because your tongue is pushing in the wrong spot? Well, for babies, it's their bones. If the tongue is up against the roof of the mouth and creates a good engagement, we can get forward and side to side or lateral growth of the midface. And so what is that? Well, if we think about the roof of the mouth, like where are your teeth? They're in the upper jaw, they're in this U-shaped bone. But what's above that? It's your nasal cavity. And essentially it's your orbits and your zygomas or your cheekbones. So if we get forward, outward, lateral growth of these jaws in the right direction in infancy, we can have somebody who has better nasal breathing, who has more symmetry in their face, which you could argue has impact on vision because now the orbits are both equally supported and not in a position where one side of the face is compressing one of the eyeballs more than the other. Symmetry in a human is important to a point. The other thing that can come with it is going to be zygomas, the cheekbones. How many people out there have you heard of, oh, she got a facelift? Really, the bones support the beauty. The bones support the soft tissue. So a breathing face is a healthy face. It's an aesthetic face. And then on top of that, all the teeth fit in the mouth. At least we should have second molar to second molar. We're kind of evolving out of wisdom teeth, and that's a testament to our jaws are getting smaller. With each generation, our jaws get smaller. There's a huge genetic composition to this. And so don't beat yourself up if your child had a tongue tie release and still is facing orthodontics. I'll tell a little bit about our story, my daughter and I, and how she still needs a palatal expander. And so growth is a continuum. Proper placement of the tongue, proper passivity of the lips and the cheeks. It's the first step in the continuum of growth to allow for a well-functioning, well-growing, symmetrical human body. And how many of us don't want our children to go through some of the aches and pains that we do? Maybe we have a different body types where we have more tension on one side of our body than the other. And that's the other highlight that I'll bring to this is manual therapy and those that specialize in relieving tension from the body, especially in infancy. We really do a disservice to our manual therapists. So today I'm going to talk mainly about structures of the oral cavity and how they impact. But I want to give light to two spaces of which I learn so much all the time. And I'm so grateful for the professionals that I work with that are also fighting the battle that I do from a dental perspective. They're often fighting a battle to support families in feeding, understanding that body tension is not inevitable, it's fixable, it's avoidable. If improving the function of a child is fixable, it's not it's avoidable. So our manual therapists, for example, osteopathic medicine, craniosacral therapists, physical therapists, chiropractic care, it there is a modality that works best for your child, but it depends on your child and the symptoms at play, what they're presenting with. So I don't want to come on here and say something's better than something else because that's not really my space to say, or because it's really symptom dependent and child dependent. So what does that mean? Well, manual therapists, those that are working on relieving tension in other areas of the body. How many of us as grown-ups have had a pinched nerve in our shoulder or plantar fasciitis, and they had to go see somebody to help support them in that movement? Maybe it was getting some adhesions in the fascia out. Maybe it was improving the range of motion through strength building and daily exercises. Those are both examples of body professionals, manual therapists who are assisting someone alleviate symptoms associated with tension or a movement pattern. So, for many of my babies, especially those with more complexities, it's not uncommon for them to see multiple types of providers. And that's not because one isn't effective. It's because at times layering on these modalities to relieve tension, improve strength can be of utmost importance in this time where we're working on maximizing a child's feeding potential and comfort. So, for example, it's not uncommon for me to have some of our physical therapists share cases with some of our osteopaths. And to me, what I tell families is each of these manual therapists brings attention to a layer of the onion. We are so complex as humans. And so, where I'm speaking to the structures of the oral cavity, they're speaking to two different techniques that are layers of the onion to help support your family. And so, yes, this can get complicated. It can get a little bit hairy where people think people are stealing their cases. Really, what I tell families is it's important to do what's working best for you in this moment. Because at the end of the day, all that all of us want to see is improvements for your family and your symptoms, and have you kind of graduate from the throes of this acute style care as quickly as we can get you there safely. Yeah, if your kid falls off the tire swing in your backyard, it's a good idea to consider some type of manual therapy to make sure that there's no spinal compression, no asymmetries that they're continuing to grow into. But when we're talking about oral ties, it's okay to see multiple people as long as you don't have too many cooks in the kitchen and as long as you're making progress. And those providers are supporting each other in their decisions and their diagnosis and recommendations. Because we'll get to this in a moment, how much disconnect there can be between different types of providers. So, those are manual therapists, body workers. Well, let's talk about function. Physical therapists have a huge overlap with function, but for breastfeeding dyad or for early feeding, it's most commonly going to be an IBCLC who is most well equipped for managing what's going on. That's not to say there aren't a number of skilled feeding therapists, speech and language pathologists, occupational therapists who are experienced and can work with dyads that are in early feeding throes of difficulty, especially when it relates to oral ties, but it's really going to be provider dependent. So just because you're seeing a lactation consultant, that doesn't mean that they have the skills to get you across the finish line because they just may not have the experience. In lactation support, oral ties are not taught, just as they are not taught in speech, in dental school, in so many different of the other assisting modalities. So, an IBCLC is somebody who's an international board certified lactation consultant. They have gone through extensive training to obtain that credential, and there's a variety of pathways that they can get there. And there are some that are more hospital based, there are some that are more home private practice based. And so for those that are IBCLCs in the hospital, it's not that they can't assist you. It's just that their patient population is more those that are newborns, those that are coming out of the hospital 2, 3 days old. They may not be as equipped to work with somebody who's 3 months old. And again, that's a blanket statement. That doesn't mean there aren't those out there who have that extensive experience in the home, in private situations. But the sample size that they're trained on is more based on those early hospital or even NICU stays, which is different than a child who's 3 months and losing weight because supplies dropping. So it may be important to ask, what was your training like? What was your experience learning about oral ties? What are the patients that you currently focus on? If somebody you call them and they say, you know what, I focus mainly on babies that are, 1 to 3 weeks old, that may not be the best choice for your 3 month old. So for our private practice or home lactation, many of them still accept insurance. So don't ask me that question. I don't know. It's really person dependent, but their sample size is going to be a little bit broader because they're dealing with a variety of issues. Maybe it's unable to take the bottle at 6 months. Maybe it's colicky type symptoms at 2 months. So the gamut of things that they're experiencing are going to be a little bit, I would say, variable And again, that's a blanket statement. I'm not saying that one of you who's listening to this isn't incredibly experienced in all of the things, and I applaud you for learning all of the things. But if we're talking about our lactation population as a whole, that's what I hear most commonly from many of the professionals that I work with and many of the parents. I already saw 4 lactation consultants. Then I went to met with this person and my mind was blown. I can't believe what they told me. And I can't believe nobody else told me these same things. Isn't everybody trained the same? And the hard answer is no, we're all not trained the same. So, what does it mean? Well, manual therapy is extremely important in alleviating body tension. Babies with torticollis or head turn preference are going to have feeding difficulties. You don't pick up your coffee cup, turn your head, and then take a sip of it. Our muscles and our fascia, our swallow pattern, it's not designed to do that in a neck rotation. We're designed to be in midline where we can be. And if we have a kiddo with torticollis or a significant head turn preference, it's just a great example of where manual therapy or body work is beneficial. I explain this to parents as if you have a pinched nerve in your neck and you just feel like, oh, I can't sleep, oh, I can't move my arm, you're going to compensate. You're going to sleep on the other side. You're going to utilize the other arm more frequently. And our babies are no different. They're going to figure out how to function as a human, even if it's to their detriment. So that's where manual therapy can be of utmost importance. Birth itself is extremely, it's traumatic no matter what way, vaginal, cesarean, short, fast, first time, 15th time, like it is a incredibly beautiful but chaotic and tension driven process. These babies come in and they've been bound up in the womb in this comfortable mama's belly for so many months, and then they come into this world where they have to go into extension. They have to utilize their reflexes, and that's another huge part of this is primitive reflexes. We're going to talk primarily about the suck reflex, and lactation consultants are extremely skilled in primitive reflexes as well, and making sure those are firing the way they should. So that leads me to the lactation or the feeding therapists. For those of you that are listening, I have a huge amount of respect for all that you do and the number of different things that you feel and the puzzles that you're figuring out every day. Because at the end of the day, as a structuralist, I can release the structures. I can, and this is what I tell families kind of bluntly, I say, I'm a structuralist. I can find a structure that could be lasered. The question is it under tension? And is it functionally impairing your child and causing symptoms? Because that's what I don't have an answer for. I tell families, I'm a breastfeeding mom of 2. I spend a lot of time researching this and learning from others. So I know way too much to be dangerous, but I don't want to be outside my scope. And I want to make sure that they're in the best possible hands to make the change that needs to be to happen, to get the improvements and get across the finish line, to get the more acute symptoms that are really harming this family, to get them going where they need to. And that's where my functional providers come in, is because they're going to work on integration of the muscles and making sure they have the strength to move forward. They're going to spend so much time with the family and making sure that they're ready to go through the tongue tie release process. They're also going to do everything they can to try to get the family out of needing a tongue tie release. If we have a baby with decent range of motion, who has decent strength, but it could be better, and we could be improving on some of the integration of how the muscles in the brain are connecting. We could be improving on that mid body strength of the tongue. They're going to do everything and they can in their power to build on the strength so that you don't have to come see us. Because I tell families this too. I don't want to have to do this procedure. If I have skilled providers that are able to really improve on the function and we're able to, it's not always just tie. Many times there are normal frenulums, normal structures that come into our office that are misdiagnosed by well-meaning providers saying it's a tie. And I just have suspicion that if we did more, if we did more manual therapy, if we did more functional training, because then I say, have you been doing any oral exercises? And they say, oh no, I was told to just breastfeed. And I go, well, you're here because you can't breastfeed, so I don't really see how that's possible. And you should be getting your fingers in your baby's mouth. And uh, that might be controversial, but just like warming up for any intensive exercise, the amount of effort that goes into feeding, it's substantial. And so that's what drives the growth. And so that's what I'm getting at. The tongue needs to be strong enough and mobile enough to drive the growth of the jaws. And that's why I, as a dentist, care so much about this. I want every family to have the feeding journey they want to have. I want these babies to be as happy as possible because there's nothing that makes me happier than seeing happy little kids. But at the end of the day, if we are not preparing families and babies for the procedure, it's not going to be successful. And so that's where I've become a little on the bossier side. And that's why we really are more of a referral based practice where babies are directly referred to us after they've been through manual therapy and been through functional therapy. And if they haven't and they call our office and they found us on Facebook, we are happy to see them for a consult. We are happy to give them a diagnosis and really weasel out where the next direction for them would be to go. We also have an amazing provider referral list on our website. So I just want to bring attention to that. It was really important for me for that to be open format because I want families to have choices because I'm not for everybody. My personality isn't for everybody. There are other release providers they could go to, but it's the same thing for any of our manual therapists, any of our functional providers. Like, we shouldn't take offense to it. We just need to support families in going where they feel like they're getting the best care. So, what happens with breastfeeding? Why does it matter? Well, the tongue needs to extend. It needs to elevate, it needs to cup, and it needs to create a peristaltic or wave-like motion. So the extension happens over the lower jaw ridge. There's kind of this cupping and engagement. If you're feeling a baby that's chompy and bitey, it's because the extension isn't happening the way that it needs to. That's most common. There are times where babies are so incredibly tense where they're extending and cupping and the lower jaw is protecting the breast from the direct bony contact, but it still feels like it. And that's because they're so darn tense. And those guys need really targeted manual therapy support. So what do we see a lot of? Well, the extension and the cupping can occur. And so that's where people will say, oh, well, like they can cup on my finger, they can cup on this type of bottle that's got a really short nipple. But then when we try to force them to have a more ideal latch on a wider shaped bottle or at the breast, or that's one reason babies will start with a good latch quote, and then they'll drop down, is because what they can't do is they can't cup and extend over the jaw ridge and then create that wave-like motion. Because think of it like a wave pool. Like the wave just kind of starts and goes, starts and goes. So we'll see cupping and extension, wave-like elevation. And the hard part is many of these restrictions are not anterior, they're not to the tip. So visually they're hard to catch if you're not putting your fingers in their mouth as a provider and lifting it up. Because I would encourage our pediatricians that are listening to this to do more than just open the mouth and look. Because if you're not lifting the tongue, you're not going to see the frenulum and if it's under tension. And then you're not going to ask better questions. You'll say, oh, it's normal for it to hurt a little bit. Oh, just keep going, it'll be fine. Oh, you can just switch to bottles and formula. So what I see a lot of is this mid-ventral restriction, especially with what's called an Eiffel Tower. So there's like this little extra webbing of attachment on the lower jaw. And so what happens is we're extending and cupping. As we go to create that wave-like motion, we lose suction. And so when we lose suction, what do? We take in air. And that's where a ton of these symptoms come from. So that's where I get really frustrated because people come in, they're like, well, my pediatrician diagnosed me and there's no tongue tie. And I say, did they put the finger in the mouth? And they say, no. And I say, well, they need to because you can't diagnose a tongue tie based on just looking inside the mouth, especially if you never even took the time to lift up the darn tongue. So what happens? Okay, the tongue is the driver. It's like the motor of the car. It is the most important thing, in my opinion, because if it's not working well, what starts to compensate? The lips and the cheeks. If the lips and the cheeks start compensating A lip frenulum or a buccal frena can become tenser and tenser and tenser as they're working to grip and maintain that suction. There's still a loss of suction in the vacuum, but a lot of times they're still able to keep the engagement at breast or bottle. So what do we see then? We see air intake. And what we're talking about here is a normal swallow pattern. What we want to see happen is good extension and elevation and that peristaltic wave. We want that tongue to be active. What also happens? The lower jaw rotates forward. Because if you think of that phrase, if you've been through and spent some time with lactation consultants, it's a nipple to nose. Well, what is that? That's the neck in extension and the jaw coming forward with a wide open gape. We need the nipple to nose, but more importantly, we need a wide open gape. Because what happens is that opens up the airway, that allows for the jaw to rotate forward, that allows for the tongue and to grip hold of the proper part of the breast that will create that letdown and good extrapolation of milk from the breast. Because if we don't have that, what's going to happen is we're going to see symptoms of aerophagia, and that could come in as spit up. It could be excessive hiccups. It could be gassiness, fussiness, back arching. It could be projectile vomiting. It could be babies don't, this is a peristaltic wave. So if that wave is compromised from the mouth to the end of the digestive tube, we see a ton of babies that haven't had a bowel movement in 10 to 14 days. And they're dismissed as, well, that happens in breastfeeding babies. Breastfeeding babies should poop every day. They just should. And so when we see that there's something going on either within the gut, which can often also be triggered by the air, or within that wave-like motion. So though colic is crying for more than 2 or 3 hours, more than 2 to 3 times a day for more than 2 weeks. It's not a diagnosis, it's a finding. And so what we see a lot of is kiddos come in and they're just so uncomfortable because they're taking in so much air. Clicking is another sign that loss of suction is occurring. And so sometimes even post frenectomy, we'll see clicking start and or get louder. And it's actually because the engagement's better than it was when they came in. So clicking is another sign. What we see a lot of is painful latch, but not painful enough for a provider to be concerned. So, and that's where it's hard because especially first-time parents, they're like, well, I don't know, like it seems uncomfortable, but they told me it was fine. And they're like, but my nipples are bleeding. And I'm like, well, that's really atypical. Or they're compressed, they're flattened. And so what is that? That's again, that shallow latch where we're not getting that same insulation of the breast as we need to. That could be that the baby's excessively chompy because they're not able to maintain that extension and that lift at the same time. So the tongue drops back and they start just kind of biting at the breast. And so we'll oftentimes see babies that are able to breastfeed but can't take a bottle. And one reason for that too is they're just not able to manage the flow. The tongue can't keep up. There's a number of other reasons too. Again, we're highlighting mainly breastfeeding in this conversation just because we're talking more about the muscle engagement that drives the growth of the jaws. But breastfeeding is something, or bottle feeding is something that people come in for where they're just not able to do it because of oral structures. Maybe they can't get a seal because the lip is so darn tight. They'll come in and say, oh, I think I have a lip tie. My child's a lip tie, somebody said. And I say, well, if there's a lip tie, I'm always going to be really suspicious of the tongue. Because in my opinion, we can have true lip ties, notching the bone really thick. We can have compensatory lip ties that show up over the first few weeks of life as that baby is just struggling to feed. And so that may be a new concept for people. Like a tongue tie, in my opinion, is there at birth. A lip tie, it's either there at birth or it shows up through compensation, because kind of like the tongue tie can have a different presentation and different composition. Is it just fascia? Is it fascia and muscle? In babies, I argue it's not fascia and muscle because that's something that comes later on. But is it to the tip? Is it in the middle? Is it really far back under the surface? And it's not called a posterior, it's still called a mid-ventral tie. Or in just like the lip, is it really thick and fibrous, notching into the bone? That one's present since birth. Or is it one that kind of shows up because those lip muscles are under tension for so long? So What else can we see? Snoring, mouth breathing. Well, a lot of times what happens with first latch, at first latch, the baby takes a deep inspiratory inhale and it clears the turbinates. And over time, those turbinates continue to clear because the babies are obligate nasal breathers. They're supposed to nasal breathe. Mouth breathing isn't cute in children. It just isn't. There's a reason it's happening. And oftentimes it starts in infancy. So we see a lot of children, parents come in, they say, my child's still mouth breathing. And you did the tongue tie release at 6 months, and which I hate that age just because there's so many complexities. And they're still mouth breathing at 3. I go, well, the tongue tie release isn't the magic bullet to clear the nose. The nose needs to continually be worked on to maintain its clearance. So what we see a lot of is there's some silent reflux that occurs because that aerophagia creates a pressure change, draws up stomach acid. It's not always that babies spit up normally. It could be exacerbated by the fact that there's aerophagia occurring as well. So we'll see babies with nasal congestion at birth, and oftentimes it's because that first latch was difficult or compromised. So what needs to happen is we need to work on getting the nose clear. We need to work on reducing the reflux, and we need to be patient because sometimes those things can't resolve miraculously. And so what'll happen is snoring or mouth breathing can begin. That silent reflux can then continue to aggravate the adenoids, the tonsillar tissue. ENTs are pretty clear to say that it's not, tonsillar and adenoid enlargement isn't caused by um, by mouth breathing. But at the same time, mouth breathing itself and what comes with it from the swallow pattern is something that exacerbates an acid process in the pharynx, and it can further irritate the adenoids and the tonsils. So maybe no, it wasn't exactly the mouth breathing, but if the mouth breathing caused the reflux, if the poor latch caused the reflux, could be the reflux along with our complicated environment that causes the adenoid and tonsillar enlargement, which have a huge impact on growth. So snoring or mouth breathing during sleep, that's not normal. And one thing we could argue is breastfeeding babies in the literature have a reduced risk of SIDS. Is it because they're breastfed, or is it because the muscles are better toned to support the airway? And that's where I'd go with that. I want, regardless of breast or bottle feeding, I would want muscular engagement for my children. So if I had a kiddo who I was unable to breastfeed for a variety of reasons, I would still focus really, really hard on building the strength of the pharyngeal muscles while they're bottle feeding. You can still do oral exercises to build strength and tone, given to you by a lactation professional or a skilled body worker who knows it's within their scope and training to do so. You can still work on muscle tone no matter what age you are. Same thing for like glute strength into your 90s. You should still be doing it. So I would just highlight that there's always something that can be done to make our kids healthier, even if our breastfeeding journey isn't exactly what we want it to be. So one other thing that I just really want to bring light to, yes, lip blisters are normal to a point, but when they're really compensatory, really grippy, the lip can't be curled up and sit neutral or passive. I would argue that there's some tension in the lips or there's lack of tone in the tongue, allowing for good engagement. Short, frequent feeds, falling asleep quickly at the breast. Babies are often called lazy. It's not true. It's just that they're working extremely hard using a ton of other musculature in order to maintain latch and get the food down. Babies are extremely adaptable and they'll do what they have to feed. And so the final thing that this is where I see a ton of babies and they come in at 3 months. They've become increasingly frustrated at the breast. They've become really they're not extrapolating as much as they were before. They're not maybe slowly declining on the curve. And maybe we're starting to see a drop in supply. 3 months is often when women go back to work. So we blame it on that. We say, oh, we're going back to work. It's harder and they're more frustrated. And that's why, because I'm not there all the time. really what happens is there's a shift in prolactin, which is hormonally driven supply. Hormonally driven supply is prolactin. And then at 3 months, that prolactin shift, because your body doesn't know if you've had 5 puppies, five kids, or one. So it's generating milk to keep your kids alive. But what happens is if there's not a great vacuum, as the prolactin drops, the body will only generate as much milk as extrapolated. And that's why night feeds can be extremely important, because that's where a huge bump in the hormones that allow for milk production come. And so that's like the hard part with sleep consulting too, is your baby should sleep 12 hours. Your baby shouldn't be sleeping 12 hours at 2 months. Like that, whenever families tell me that they're a great sleeper, they sleep all night, I cringe a little, because I think, oh man, where did they get this information? And how can I help shift their mindset that that's not appropriate? Because a lot of times those babies are dropping weight because they need that night feed too. So if there's not a good vacuum, what happens is the body will stop producing as much milk. And then we'll see this decline. And then it's harder to come back from that. So that's where I see a lot of frustrated families. They come in at 3 months. They said, this was pointed out to me in the hospital, and they told me it was no big deal. And it's a baby almost tied to the tip. And they say, and we have a local hospital here who's notorious for that. And I won't say names because I don't want to get in trouble, but it's almost supervised neglect. Like at this point, it's supervised neglect. A, they didn't look. B, this kid's tied to the tip, which we can all agree in the medical community is considered an oral restriction because there's no mobility of the tongue. And it's just hard and frustrating for these families because they come in and they're just crying. And it's hard to get that milk supply back without a lot of work, because at that time that you got to get the baby comfortable back at the breast. You got to get them comfortable with the flow. You got to get them stronger. And then at some point you got to think about releasing the oral ties, but we're in a rush, and it's never good to be in a rush in this space. So I think the biggest thing that I would say is if you're asking questions repeatedly and you're not getting answers, it's time to continue to trust your gut and know that you're on the right path. Your intuition is right when it comes to your children, and you shouldn't be brushed off. So keep asking questions. If something feels off, it probably is. Trust your gut. Find a skilled provider. I have a ton on my website. If you're looking for resources, like you live in Alabama and you're like, who can help me? I have a ton of amazing providers that can do virtual, and they can make more progress virtually than many can in person because their skill set and their experience is so vast. So trust your gut, find the right people, do your due diligence, ask good questions. I had a mom ask me the other day, she said, what makes you feel that you're equipped to handle this case? And it was an orthodontic case. And I loved it. I loved that question because she challenged me. And I was able to say, in my experience, I have treated many children with this presentation. I feel very well equipped to treat your child. If you're asking questions like that and they're like, well, like I took a course and I learned like a little bit, and I think this is the right thing. I think this will help you. It seems like this is going to help you. Like those, to me, I tell my providers that I work with, come to consultations with empathy, but direction. Put timelines on things, provide resources, and make sure that families are feeling the experience that you have, because that's what's going to help them feel supported. And we have experience. Like these are the things we see improvements in. So again, ask questions, challenge your providers, get second opinions, because I encourage that too in my office. I say, you know what, go get another opinion. Here's a couple of names. I want you in the people's hands that you feel the best in. And if that's not me, that's okay. But I just want you to take this knowledge, and I know it's new to you, and I want you to start asking questions because you have been for this long. And I'm so happy you're here, and I'd love to be able to help you. And I hope this gives you some direction. So I ask questions and listen to podcasts, listen to social media, but do your own research. And that's where I'd also highlight our website. We have a ton of research on our website, and it's a fantastic landing page. If you go to www.untetherederwayhealthcenter.com, down at the bottom, there's a click to get to our resource page, and it's literature that spans the life. So there's breastfeeding research, there's craniofacial growth research, there's sleep-related research, because at the end of the day, this is about jaw growth, but it's about overall health and wellness. So I know this has been a ton of information, and I'm happy to do a deep dive on any of these symptoms more and more. But I hope that this sheds some light and helps people continue to ask better questions. And I'm just really excited you're here on this journey, the Untethered Airway podcast, and I hope you keep following along.
Thank you for joining us on the No One Told Me, the Airway Health Connection, the Untethered Way.
We hope you're leaving with new insights and feeling empowered to take charge of your airway health.
If you enjoyed this episode, be sure to subscribe and share it with anyone and everyone who needs to hear it.
To learn more or get in touch, visit us online at untetherediRwayHealthCenter.com.
Remember that when you breathe better, you live better.